In this supplementary video to our chapter on pediatric intraventricular and periventricular tumors, we will provide a brief overview of the chapter contents pertaining to the classification and predominant subtypes of pediatric intraventricular tumors, and the general surgical approaches to tumors in this region. However, the main focus will be on revisiting the third ventricle and the endoscopic era of pediatric neurosurgery. We will present two cases that highlight the various approaches and methods for third ventricular tumor biopsy and resection. The subtypes of pediatric intraventricular tumors are predominantly categorized by location. The entirety of the ventricular system can be the origin for ependymomas and subependymomas, as well as pilocytic astrocytomas. From the lateral ventricle arise the most variety of tumor subtypes, including SEGA, central neurocytoma, choroid plexus papilloma and carcinomas, meningiomas, and high-grade gliomas. Within the anterior third ventricle, central neurocytomas, craniopharyngiomas, and pilomyxoid astrocytomas are predominantly seen. And within the posterior portion, there is a predominance of pineal region lesions, including pineoblastoma, pineocytoma, teratoma, and germ cell and tectal tumors. The fourth ventricle is notable for medulloblastoma and epidermoid cysts. A review of the surgical, radiation, and systemic-based treatment modalities can be found in the chapter on Table 1. Microsurgical approaches to tumors of the lateral and third ventricle include transcortical approaches with dynamic retraction or tubular retractors. For the anterior third ventricle, an interhemispheric transcallosal dissection or a subfrontal translamina terminalis dissection may also be performed. For the posterior third ventricle, interhemispheric transsplenial, occipital transtentorial, or infratentorial supracerebellar approaches can be taken. With transcortical neuroendoscopy, a minimally invasive approach for third ventricular tumor biopsy or resection is possible. These images illustrate various possible trajectories that allow for CSF diversion and tumor sampling in both the anterior and posterior third ventricle. This can be achieved by means of altering the cortical entry points and trajectory, and using a combination of rigid and flexible endoscopes. Various criteria guide selection of which intraventricular tumors are amenable to biopsy versus resection, including tumor size, calcification, infiltration, CSF dissemination, multifocality, metastasis, and a relationship to the ependymal surface. Case 1 demonstrates the option of utilizing neuroendoscopy for both CSF diversion and tumor sampling. This patient is a 3-year-old female under a surveillance program for congenital retinoblastoma. As part of the program, imaging studies of the brain revealed a progressively enhancing and enlarging mass situated within the pineal region. Given the suspicion that this represented trilateral retinoblastoma and the remainder of the metastatic disease was negative, and risk for progressive tumor growth and ventricular obstruction, the patient underwent endoscopic third ventriculostomy and biopsy. Using navigational guidance, a right frontal approach was taken through the foramen of Monroe and into the anterior third ventricle. The third ventricle was inspected, and a third ventriculostomy was performed in a standard fashion. There was clear visualization into the prepontine cistern, and there was no noted opacity or tumor dissemination. The endoscope was then steered posteriorly to inspect the posterior third ventricle, where the tumor mass was readily visible, distorting both the posterior and habenular commissures anteriorly. Tumor mass was emanating between these two structures, consistent with a pineal gland origin. Utilizing cup biopsy forceps through the steerable scope, 2 specimens were taken between the commissure and sent for permanent pathologic interpretation. Modest amounts of hemorrhage were noted, which were controlled with irrigation. The The third ventricle was re-inspected, noting good CSF pulsations from the ventriculostomy, and the area of biopsy was also visualized, noting excellent hemostasis. In this case, we demonstrate recurrent third ventricular tumor resection. The patient is a 16-year-old female with a history of right parietal choroid plexus carcinoma that was resected 4 years prior and treated with chemotherapy. She was found to have recurrence in the third ventricle on interval imaging and subsequently taken for endoscopic resection of the tumor. Inspection of the intraventricular space indicated a tumor mass situated within the anterior third ventricle. The tumor appears consistent with the child's history of a choroid plexus tumor in that it was hypervascular and multilobulated. At the most anterior margin of this tumor, bipolar cautery was used to create a subependymal plane at the tumor interface. During this maneuver, there was brisk venous hemorrhage consistent with a subependymal vein or a vascular pedicle of the tumor mass itself. This was controlled with bipolar cautery. The tumor was removed nearly en bloc with biopsy forceps. The hemorrhage noted at the tumor interface was further controlled utilizing bipolar cautery and constant irrigation.